Our next speaker is Michael Germain. Dr. Germain is a transplant nephrologist at Baystate Medical Center and is a professor of medicine at Tufts University School of Medicine. One of his research interests is the predictors of progressive loss of renal allograft function. Dr. Germain will also share his center's recent experience with using TruGraf as surveillance during COVID-19. Dr. Germain.
Our immunosuppression protocol in our program is CAMPATH induction, monotherapy with Envarsus, and we also are a protocol biopsy program. We have protocol biopsies done at 3 months, 12 months post-transplant, and we do follow-up biopsies 1 month after treatment for rejection. We do biopsies for increased DSAs, rising BK viruria, and we do biopsies before and after immunosuppression conversions, such as switching to belatacept or mTOR inhibitors. We also do biopsies for cause when there's proteinuria or increased creatinine, for example. Let me discuss the first case. This is a young woman, 36 years old, who was transplanted September 9th of 2019. Due to the COVID pandemic, we've been limiting face-to-face visits to patients who have an absolute need for such visits, and talk with her this time was through telehealth. She would have been due for a protocol biopsy due to the fact that she was going to change immunosuppression. Her original kidney disease was IgA nephropathy. She has immunosuppression with cyclosporin MMF, a baseline creatinine of 1.2. Her active issues are gum hypertrophy and hair growth, believed to be a complication from cyclosporin. This is the reason that we're switching her to belatacept. She had 2 pregnancies, and she's on cyclosporin because she developed diabetes with the pregnancies, and we were concerned she would develop post-transplant diabetes with tacrolimus. But now she's bothered by the hair growth and gum hypertrophy. So our plan was to switch her to belatacept, and instead of the protocol biopsy, we did a TruGraf, since she was very reluctant to come into the hospital and be exposed to other patients or staff that might have COVID. I noticed that a lot of our transplant patients are very, very scared about getting COVID. TruGraf showed graft excellence, and so we proceeded to converting her to belatacept. She also had negative DSAs, and we were comfortable then proceeding with belatacept conversion, and we plan to recheck the TruGraf in 1 month. A second case is a 24-year-old woman I've taken care of since she was a child. She has congenital dysplastic kidneys, megaureter, reflux nephropathy with multiple reimplantations. She also has bladder dysfunction. Her father had a similar condition and ended up on dialysis and had a kidney transplant, which has been successful for a number of years. She had a living unrelated donor transplant from her boyfriend, and this was a preemptive transplant, so she was not on dialysis. Our immunosuppression was monotherapy with Envarsus XR, and although she had excellent kidney function initially with a creatinine of 1.1, it rose quite a few times after the transplant, and there were complications with borderline acute rejection. She was treated with steroids that was finished in October, and then she had multiple episodes of bladder dysfunction as well as possible transplant stenosis of the ureter. So her creatinine now remains between 1.6 and 2, and the creatinine does fluctuate. There was a repeat biopsy after her initial rejection that showed 10% interstitial inflammation, but no evidence of acute rejection. There was interstitial fibrosis. Her DSAs and C4D have been negative. She has a very thick, small bladder, and she had a nephroureteral stent that's now been removed. Because of all these complicated issues, as her creatinine does rise frequently, there's often the question of whether we should do a kidney biopsy. She's quite resistant to any interventions, does not want any further urologic procedures, and she also does not want to have a kidney biopsy, especially with the COVID epidemic going on. She had an unrelated episode of Coombs positive anemia in March, so this is a very complicated patient. So our plan was, although we might usually do a repeat renal biopsy with an increased creatinine, especially with the cellular acute, with the history of cellular rejection, In this case, we did a TruGraf, and we got a transplant excellent result, which reassured us that acute rejection was not playing a role in her fluctuating creatinine and that a biopsy was not necessary. In summary, TruGraf has allowed us to eliminate protocol biopsies at this time in the COVID era, and many patients do not want to have these elective procedures done. But we will likely continue to replace our protocol biopsies with TruGraf now that we've had more experience and feel comfortable with the results that we're getting. Since we also convert from calcineurin inhibitors to belatacept frequently, monitoring with TruGraf allows us to at least avoid 2 biopsies and also monitor some months after the conversion to make sure there's no episodes of acute rejection. Thank you for allowing me to discuss these cases with you today and our use of TruGraf.